Good evening. I'm very happy to be delivering this lecture from Boston. It's an honor to get invited to give the lecture for Quest. I want to start off by paying my tributes to my guru, Dr. Kakala Subba. It has been my good fortune to have known and trained under Professor Kakala Subba. Sir has been the most influential man in my life and a source of constant inspiration, strength, and a role model. I realize now more than ever the greatness of this man. I met some very accomplished people in Boston and in elsewhere in US, but none can match up to him. I am forever grateful to his guidance, kindness, and teaching. Now, getting on with the topic of lung cancer staging, when you talk about lung cancer staging, we are talking about two different types of staging. The one the radiologist perform, and the other the pathologist performs. We are involved in the clinical staging of lung cancer. This is by far the most commonly performed staging for lung cancer. All the information before tumor is removed is taken into account. This is based on physical examination, the data we gather from imaging studies, and also other invasive procedures such as bronchoscopy. This is by far the commonest staging that is used, and it is applicable for all cancers, including advanced lung cancers. The pathological staging, on the other hand, is done after tumor is resected. It is done for local disease or early lung cancers. This is a true stage of the lung cancer and therefore the gold standard. But unfortunately, many lung cancers at the time of diagnosis are already in advanced stage. Therefore, it is not possible to perform pathological staging or confirmation of the tumor where it is suspected in all the parts of the body. Why should we care about staging? We know that the stage of the cancer determines the treatment options. It also helps us to predict the prognosis of the cancer, but it is also very important to enroll patients into various research and clinical trials. I will start off with giving you some background about the most current edition of lung cancer staging, that is the 8th edition of TNM staging, and the changes that were incorporated in the latest TNM staging for lung cancer. The staging is revised and devised by International Association for the Study of Lung Cancer. This association maintains a huge database, and this association also publishes the very famous Journal of Thoracic Oncology. For revising their 8th edition, they looked at the outcomes of over 77,000 patients with lung cancer between 1999 and 2010. And this group of patients included those with non-small cell lung cancer and also those with small cell lung cancer. As non-small cell lung cancer is the more common cancer we see, naturally there were more patients with non-small cell lung cancer in this cohort. The 8th edition was implemented in January 2017. It took some time for everybody to adapt and use it in their routine clinical practice. Now it is very commonly used. The TNM system is used for both small cell and non-small cell lung cancer. This is similar to what was advocated in 7th edition. But compared to the previous 7th edition, there are multiple changes. The changes were mostly in the T and M designations. They have not changed anything in the nodal staging. So as you know, the TNM staging stands for tumor, node, and metastasis. So the first component of TNM staging is T staging. The T stage of lung cancer is based on the size, the involvement of the carina and the distance from carina, the presence of atelectasis or pneumonia in the lung distal to the cancer, invasion or involvement of adjacent structures in the chest wall, mediastinum, and presence of malignant nodules elsewhere in the lung. So this is a very busy chart showing the various T designations that are possible in the revised 8th edition. I will go into details to make it easy to understand. So, but before we go further, we have to understand what was the reasoning behind changing the T stages. After extensive study and outcome analysis, we have come now to realize that tumor size is incredibly important. Each centimeter increase in the tumor can adversely affect the prognosis. Therefore, size of the tumor is very important, and predicting prognosis based on size alone is very important. The endobronchial lesions are not that important in the sense endobronchial lesions that can be resected usually carry the same prognosis as long as they're not involving the carina. The extent of atelectasis or pneumonia in the distal lung resulting from endobronchial lesion again is not important. It is just important to know if there is atelectasis or pneumonia. We do not have to worry whether it's a lobar atelectasis or pneumonia or sublobar atelectasis or pneumonia. What is new in the 8th edition is the recognition of importance of diaphragmatic invasion. If diaphragm is involved, it carries poor prognosis. Then other thing which is not considered that important in 8th edition is the mediastinal pleural invasion. In the 7th edition, a lot of emphasis was placed on mediastinal pleural invasion, but then in subgroup analysis, it was realized that maybe mediastinal pleural invasion by itself does not affect the prognosis that much. So compared to the 7th edition, in the 8th edition, we have to remember more numbers, but these are easy to remember. So the tumors go from 1 centimeter up to 7 centimeter, up to 5. Every increment in size changes the T designation. From 1 to 3 is T1. For every centimeter increase, there will be a change in the letter from T1A to T1B to T1C. T2A and T2B are based on the sizes 4 and 5. Anything between 5 and 7, that is over 5 and up to 7, is considered T3. And the first time ever, based on size alone, we can confer a T4 stage to the lung cancer. Anything measuring more than 7 centimeters is a T4 lung cancer. So now it becomes important to understand how we measure lung cancer. So we have to choose the longest axis diameter. This diameter may be in any plane, transverse, coronal, or sagittal. The longest axis diameter represents the T stage. When you are looking at cancers, it is also important to differentiate cancer from distal process such as collapse or consolidation. Understand when a pleural tract is thought to be part of the cancer and what do these speculations represent. So this is a slide with 3 examples. And the first one, there's a cavitary nodule with aerated lung surrounding it. So nobody would think that this is involving visceral pleura. Whereas in the middle one, the nodule is along the left major fissure. As you see here, there is some retraction of the fissure and also some thickening of the fissure. In the third one, there's a bigger mass with a lot of speculations extending all the way to the pleura. So if you're looking at this one, definitely I would say the first one is probably not involving pleura. The second and third, perhaps there is involvement of the visceral pleura. But on imaging, it is very difficult to predict visceral pleural invasion. The best method is to do elastin staining on histopathology. So when pleural tags or speculations are present, we have to take a few things into consideration. before determining the visceral pleural invasion. If the pleural sacs are thick, bulbous, and nodular, this is more likely that there is visceral pleural invasion. Thin, delicate spiculations do not always indicate visceral pleural invasion, even when they reach up to the pleura or the fissures. At the same time, even if there is no pleural sac reaching up to visceral pleura, there can still be microscopic invasion. So overall, the accuracy of the radiology is not that high, and it is around 71% in the presence of pleural nodules or pleural sacs which are bulbous. Otherwise, our sensitivity is very low. So now in the three examples I've shown you, the first one did not have any visceral pleural invasion. The middle one had invasion on pathology. The third one, which I thought would have visceral pleural invasion, did not have any visceral pleural invasion on pathology. So what we saw as spiculations reaching up to the pleural surface was mostly a desmoplastic reaction. When you're measuring a tumor from a distant process such as atelectasis and pneumonia, we can use a few tricks to determine the extent of the tumor. If you have a combined CT PET, the tumor would have more FDG avidity compared to the distal collapse. But sometimes if it is a distal pneumonia, pneumonia can also have increased FDG uptake. In such instances, it may be difficult to differentiate between the two. But the importance of measuring tumor is it may affect the stage. So if the tumor is causing distal collapse or atelectasis, we know it will be at least a T2 tumor. But in this instance, the tumor measures more than 7 centimeters, so therefore it is a T4 tumor. It changes the stage of the cancer and the treatment options that are available for this patient. Even if you don't have the PET imaging, by using contrast enhanced CT, we can usually make out the extent of the tumor. The tumors tend to enhance much to a lesser degree compared to the atelectasis. As I can see here, the tumor itself is hypodense compared to the enhancing distal atelectatic lung. When the tumors are solid, the TNM staging, what I was described so far, would apply. For every increase in a centimeter, there is a change in the letter along with the number of the T stage. But if the tumors are subsolid, when you say subsolid nodules can be completely ground glass, or they may have a part solid component. When the tumors are subsolid, the classification or the designations differ. Up to 3 centimeters for a pure ground glass nodule, it is called T1 in situ. If there is a solid component measuring 5 millimeters or more, then it is called minimally invasive subsolid cancer. Again, here we do not want to make distinctions from 1 centimeter to 2 centimeter. It is just called T1, minimally invasive, up to a size of 3 centimeters. For T2 tumors, it is anything more than 3 centimeters, and but less than 5 centimeters or equal to 5 centimeters, or a tumor with any of the following features. If it involves the main bronchus, but it is not involving the carina, even if it is within 2 centimeters from the carina, but is not involving carina, it is still a T2 tumor, a tumor which invades visceral pleura. And we already realized that we are not very good at predicting the involvement of visceral pleura, or any tumor that causes distal atelectasis or pneumonia. So again, this is a diagram showing how this tumor can be located at various locations. As long as the carina is not involved, as long as these tumors are available for surgical resection, the prognosis would not be that different. Then we again to re-emphasize the point that any amount of atelectasis or pneumonia would make it a T2 tumor. It doesn't have to be complete lobar atelectasis or pneumonia. So here on the left side there's endobronchial lesion. causing distal collapse of the entirety of the left upper lobe. This is a T2 tumor. And even here, which is causing partial pneumonitis of the right upper lobe, is also a T2 tumor. So the reasoning is, as long as you can resect the tumor, even by performing a pneumonectomy, the prognosis would remain the same. Therefore, it is more important for us to understand if the tumor can be resected or not. In most situations, if the carina is involved, resection becomes an impossible task. Therefore, those tumors carry worse prognosis. Whether it is involving a lobar bronchus or a mainstem bronchus, as long as it can be resected, I would still have a better prognosis. Again, total atelectasis or pneumonitis does not really matter, because what is a partial atelectasis can become total atelectasis and vice versa. So this is something which can change over time and does not really affect the prognosis. A T3 tumor measures more than 5 centimeters but is less than or equal to 7 centimeters and in greatest dimension again. But besides this, there are many other features which can also confer a T3 designation. If there is a satellite nodule adjacent to the primary tumor and the nodule is located within the same lobe, this would become a T3 lesion. And any tumor that is involving the chest wall, so by default, any Pancoast tumor would be a T3 tumor. And tumors that cause diaphragmatic paralysis by affecting the phrenic nerve would also be a T3 tumors, and tumors that involve the parietal pericardium are also considered T3 tumors. Before, a lot of emphasis was placed on assessment of mediastinal pleura, but now that is not a factor anymore. So determining of chest wall invasion is not always easy. We can look at the imaging findings into divide them into two broad categories: findings that suggest definite involvement and findings that may suggest possible involvement. So if you want looking for definite involvement, so there should be a clear chest wall mass, there should be associated rib destruction. There are a number of other signs for possible involvement, such as obliteration of extrapleural fat, a length of contact of more than 3 centimeters, or length of contact to tumor diameter of more than 0.5, and also obtuse angles at the pleural surface. But in reality, these are all soft features. We cannot definitely say that there is involvement of the chest. So in this instance, nobody would have any doubts regarding the chest wall invasion, because there is obviously destruction of the rib and also clear extension of the chamber into the posterior chest wall. So even here anteriorly, you can see there is involvement of the chest wall. And this is a diaphragmatic representation of the same. In this instance, however, our accuracy is not that great. We know the tumor is reaching up to the pleura, but there is no clear chest wall mass. There is no clear destruction of the rib. And but the contact is more than 3 centimeters. And if you calculate the contact to diameter ratio, it is also more than 0.5. So there's a good possibility that this is probably involving the chest wall. But in most advanced centers, if there is no other evidence of distant metastasis, these tumors are typically taken for surgery, and if required, chest wall resection and reconstructions can be performed. A T4 tumor is any tumor that measures more than 7 centimeters in the greatest dimension, or if there is a nodule in the same lung but different lobe. Any involvement of the carina or any involvement of the diaphragm would also make it a T4 tumor. In addition, involvement of the mediastinal structures and involvement of recurrent laryngeal nerve would also make it a T4 tumor. So I wanted to remind you that before we said if the tumor is involving phrenic nerve and causing diaphragmatic paralysis, that will be a T3 tumor, whereas the direct involvement of the diaphragm is T4. Involvement of the recurrent laryngeal nerve and vocal cord paralysis would make it a T4 tumor. So in this instance, a primary is in the right lower lobe, and there's a satellite nodule in the right middle lobe. Therefore, it's a T4 because the metastatic nodule is in a different lobe. So we said rib destruction is a T3 tumor, but there is an involvement of the vertebra with extradural soft tissue that becomes a T4 tumor. It is important to look closely at the vertebral body destruction and associated soft tissue because it has a lot of bearing on treatment, particularly for pancreas tumor. If the tumor is involving the neural foramina, most radiation oncologists would still give full therapeutic radiation dose. But if the tumor is within 1 centimeter of spinal cord, it becomes a challenge because they cannot give full radiation dose that may cause some cord injury. So that might affect the treatment options. So when you look at the neural foramina tumor, please measure the distance from spinal cord and make sure that it is at least a centimeter or over uh, for the radiation oncologist to deliver full dose radiation therapy. Similarly, there are also imaging features for predicting mediastinal invasion. The gross invasion is pretty obvious, and when there is gross invasion of the mediastinum, these patients are not surgical candidates. So the features of gross invasion are extensive replacement of the mediastinal fat, the mass if it is surrounding or invading mediastinal vessels, heart chambers, trachea or esophagus. But there are also a number of soft signs, the signs which suggest possible invasion, the contact of more than 3 centimeters or contact over 90-degree circumference for circular structures such as thoracic aorta, obliteration of fat planes between the mass and the mediastinum, and compression of mediastinal structures. In most instances, if these are the only findings without any other evidence of metastasis, the surgeons would still take up these patients for surgery. And depending on what they find on operating table, they'll decide whether to proceed with surgery or not. So for example, in this case, this mediastinal invasion is pretty obvious from the left upper lobe cancer. It is replacing most of the mediastinal fat. As you can see, the esophagus is being displaced to the right, and there is also most likely involvement of the posterior wall of the esophagus. So this is a pretty clear-cut case of mediastinal invasion. So this would not be obviously a surgical case. The same thing in the coronal plane. The superior sulcus tumors, as I said, by default are T3 tumors because they involve the chest wall. But if they, in case, are involved the brachial plexus, the tumors are upstaged to T4. So now we'll go on to the assessment of lymph nodes in lung cancer. The lymph node assessment is very important, and it is something as radiologists we are not good at predicting if the lymph nodes are affected or not. When you're looking at the lymph nodes, it is important to understand the location of the lymph node, then understand how we measure the lymph nodes, and correlate with the associated FDG uptake. But in almost all situations, we have to do biopsy to confirm our findings. So the classification that is used for lymph nodes and lung cancer are in accordance with International Lung Cancer Staging Classification. So here, as you see, there are a lot of lymph nodal stations, the numbers associated with them. The easy way to remember is nodes which are in 2 digits. These are all N1 lymph nodes. The N2 and N3 lymph nodes are in single digits. All the mediastinal lymph nodes are in single digits, and the low cervical or so-called supraclavicular lymph nodes is the first number. When you talk about the lymph nodes, one thing which often causes confusion is the upper and lower paratracheal lymph nodes. On the right side, there's a different anatomical boundary, and on the left, there's a different anatomical boundary. So the boundary between the upper and lower right paratracheal lymph nodes is by the left brachiocephalic vein as it arches over the mediastinum and joins the right innominate vein. It forms an arch. So that is the anatomical boundary. Whereas on the left side, the upper and lower left paratracheal lymph nodes are separated by the superior border of the aortic arch. There is one other important nodal group we should be aware of for the purpose of lung cancer staging. That is the level 1 lymph nodes. These are called low cervical lymph nodes, supraclavicular lymph nodes, and also sternal notched lymph nodes. The first thing is the level 1 lymph nodes in thoracic oncology is different from level 1 nodes that are used for head and neck oncology. So the level 1 nodes in thoracic oncology, they extend from the lower border of the cricoid to the superior borders of the clavicles and superior manubrium. So this is the location for level 1 lymph nodes. So I can see here, so any lymph nodes, some people might call this as lower jugular lymph nodes, but they are in fact level 1 lymph nodes for thoracic oncology because it is below the level of the cricoid cartilage and all the way up to the clavicles here. So these are all level 1 lymph nodes. In head and neck oncology, the level 1 lymph nodes are the submental, submandibular lymph nodes, whereas in thoracic oncology, the supraclavicular, scalene, and low cervical lymph nodes are level 1 lymph nodes. So depending on who you are talking to, so be careful in using your level 1 lymph node terminology. So as we know, the lymph nodes are measured in short axis. So the short axis determines the true significance of the lymph node size. So in general, any lymph node that is greater than a centimeter in short axis is considered a abnormal lymph node unless proven otherwise. But lymph nodes in mediastinum themselves can have a great variation in their normal short axis diameters. For example, subcarinal lymph nodes can be up to 1.5 centimeters and can still be totally normal lymph nodes. But for all practical purposes, we take 1 centimeter diameter in short axis as our cutoff to further investigate these lymph nodes. If the lymph nodes are small, if they contain fatty hilum, if they are reniform shaped, this might suggest that these lymph nodes could be benign, but every lymph node, irrespective of its size and morphology, is still routinely sampled to figure out the end status. So we know that when we talk about lymph nodal staging, there are 3 different stages, N1, N2, and N3. N1 is typically described as metastatic lymph nodes in the hilum. But here it's not just hilum. Any lymph nodes which are along the bronchi going up to the hilum are considered N1 lymph nodes. So these also include some intrapulmonary lymph nodes, peribronchial lymph nodes, all the way to the hilum. So any lymph node is considered as N1 lymph node. These lymph nodes can be involved either by direct continuity with a tumor, or that can be a truly metastasis from the primary to the lymph nodes in the lung, around the bronchi, or in the hilum. The next to the ipsilateral mediastinal lymph nodes is N2 lymph nodes, and subcarinal lymph nodes are always considered as ipsilateral lymph nodes. Say, for example, this subcarinal lymph node was enlarged with a tumor in the left lung, though it is slightly to the right side, it is still considered as ipsilateral lymph node. So subcarinal lymph nodes are always considered ipsilateral lymph nodes, whereas other lymph nodes you have to carefully assess whether they are on the right or on the left to determine if they are ipsilateral mediastinal lymph nodes or contralateral mediastinal lymph nodes. Any lymph nodes in the same side as the tumor, mediastinal lymph nodes on the same side as the tumor, are N2 lymph nodes. N3 lymph nodes, anything on the opposite side, contralateral hilar, contralateral mediastinal, or any level 1 lymph nodes, either on the same side or other side, are N3 lymph nodes. We are not very good at determining the metastasis to the lymph nodes. 44% of the metastatic lymph nodes are less than 1 centimeter in short axis diameter. And more than 77% of the lymph nodes which measure greater than a centimeter in short axis, are in fact non-neoplastic lymph nodes. Therefore, our assessment is not good. CT, the accuracy was around 50 to 60%. When we used PET fused with CT, the accuracy improved. The initial reports indicated the accuracy of over 90%, but now we realize that accuracy is around 80%. So the surgeons tend to biopsy these lymph nodes before taking up these patients for surgery. So there are a number of surgical techniques. I'll talk about these techniques also to sample the lymphs. So we can do mediastinoscopy, or more commonly we can do bronchoscopy. The bronchoscopy can be either rigid or flexible bronchoscopy. So the difference between the two is the reach. Rigid bronchoscope can go into the trachea, it can go into the main bronchi, but it cannot make these turns. A flexible bronchoscope, on the other hand, can be navigated into the lobar bronchi. It is difficult to go into the segmental and subsegmental branches, but it is more maneuverable, and it can be parked into the lobar bronchi to pass a forceps or a guide wire through this flexible bronchoscopy to sample more distal tumors and lymph nodes. The other way to sample the smaller lymph nodes or more distant lymph nodes is by using electromagnetic and navigational bronchoscopy technique. I'm interested in this technique because imaging is a huge part of this technique. These patients get a CT scan. The CT scan is used as a road map. The patient is placed on a special electromagnetic table. Then we try to match up the anatomical landmarks on the CT scan with bronchoscopy, match the vocal cords, carina. Then we use CT as a virtual guidance to pass smaller wires, catheters, to the flexible bronchoscope to reach distally into the lung to sample peribronchial lymph nodes or distant tumors. So this is a very interesting technique, and the results are very promising, particularly for patients who cannot undergo percutaneous biopsy, patients with emphysema, or patients in tumors or lymph nodes in hard to reach locations. So this is the anatomy. This is the flexible bronchoscopy through which a catheter can be passed. We can use a forceps to sample any of these lymph nodes. But more commonly, the surgeons and interventional pulmonologists are using endobronchial ultrasound. So this again uses a flexible bronchoscopy through which ultrasound probe is passed. This allows visualization of the tumor directly, and you can actually see the needle going into the tumor when you're taking the sample. So this is a lymph node in the left hilar lymph node. It was a metastatic squamous cell carcinoma, and you can visualize the needle when you're taking the sample. So this has become very popular. A few years ago, it was Mediastinoscopy that used to be the gold standard, but now people are using endobronchial ultrasound more commonly. So EBS has become the newer gold standard. The results are comparable to mediastinoscopy. So by using these techniques, the bronchoscopy, endobronchial ultrasound, or sometimes even esophagoscopy, endoscopy, we can sample most of the lymph nodes. But there are some lymph node locations that require surgery. These are the AP window lymph nodes, the level 3 lymph nodes. So for these lymph nodes, it's not easy to access these lymph nodes with any of these techniques. So if you find these lymph nodes, it is important for the surgeon to do a surgical technique, which could be either a mini thoracotomy, Chamberlain procedure, or a VATS procedure to sample the lymph nodes to determine the nodal status. The third component of the TNM staging is the M staging. So M staging also underwent some changes in the latest classification. So any metastasis which is confined to the thorax is called M1A. If the metastasis is outside the thoracic cavity, it can be either M1B or M1C. based on the number of metastases. If there's only one extrathoracic metastasis, this is called M1B, and if there's more than one extrathoracic metastasis, that is labeled as M1C. The reasoning is patients who have only intrathoracic metastasis tend to have better prognosis than those who have extrathoracic metastasis. But again, if you do a subgroup analysis, patients who just have one metastasis outside the thorax also tend to have a better prognosis. So therefore, M1A and M1B have slightly better prognosis than patients who have multiple extrathoracic metastases. So this distinction now has become very important to predict the prognosis in these patients. So in this patient, there's a primary tumor. There's a nodule in the contralateral lung. Therefore, this becomes a M1A disease. If the patient has pleural effusion which is confined to the thorax again, therefore it's a M1A. If the patient has got involvement of the pericardium, again it is confined to the thoracic cavity, so therefore it is M1A. If the patient, on the other hand, has extrathoracic metastasis, the number becomes important. If there's only involvement of one organ, like in this patient who has involvement of the adrenal gland only, this is M1B. This can also be called oligometastatic disease, but now the number is becoming a little controversial. When it started off, oligometastatic disease meant only one metastasis. Now people have extended the number to 3 and 4. So even if you have 3 or 4 metastatic sites, it is still considered oligometastatic disease. But generally speaking, when we are talking about oligometastatic disease, which can confer good prognosis, we are talking about single metastasis outside the thoracic cavity. Or you may have M1C disease where there are more than one extrathoracic metastasis. Now this may be multiple metastasis in a single organ, such as in brain, or it may be a single metastasis to 2 or more organs. So either way, it will be M1C. So the number of metastases is important, not the number of organs. So to quickly summarize few things. One, sometimes people get confused about the location of the nodules. If the nodule is in the same lobe as the primary, this is a T3 tumor. If the nodule is in the same lung but different lobe from the primary, that is a T4 tumor. If the nodule is in the contralateral lung, that is M1A, or metastasis confined to the thorax. See, another tricky situation is many patients with lung cancer have multifocal cancers. They may have cancers of different histologies. When you have patient with 2 different cancers, different histologies, each of these cancers gets staged separately. So this patient has got 2 nodules, one in the right upper lobe, other one in the right lower lobe. So these were of different histologies. The lower cancer was a neuroendocrine carcinoma. The upper cancer was a lung adenocarcinoma. But both are small. So we stage them independently. So we can say that this patient had 2 stage 1 cancers, which has much better prognosis than saying this patient has got a cancer which can be a T4 cancer, T4N0N0, because this was a metastatic nodule from the primary, say the larger one in the right lower lobe. This would be a T4 because it is located in a different lobe, but in the same lung. The other situation is multifocal lung cancers, which tend to be predominantly ground glass or subsolid in density. So it is not uncommon to have multiple subsolid nodules, all presumed to be multifocal lung cancers. These tend to have a very indolent course. In fact, many patients may die with these cancers, but may not die from the cancers themselves. So when you have multifocal lung cancers, when you're staging them, you choose the biggest nodule that determines the highest stage and ignore the other cancers. You do not call them to be T3 cancers, or you don't want to call them as T4 cancers or M1A cancers. They are called multifocal lung cancers, but the stage which is assigned to this patient is based on the largest subsolid nodule. I do not know the experience in here in India, but multifocal lung cancers are extremely common. They are very common in screening population also. So in a study I have done, we found multifocal cancers account for up to 8% of screen detected lung cancers. So when you have multiple tumors in the lung, it also becomes important to understand whether these are separate primaries or we are dealing with metastasis from a dominant cancer. So it's not easy to differentiate between the two, but there are some helpful hints. I would consider something to be separate primaries if the imaging appearance or the metabolic uptake of these tumors is different. Say, for example, a patient has a solid nodule in one lobe, then you also find some other nodules elsewhere in the lungs which are of ground glass density or part solid. Then I would think that this patient has multifocal lung cancers. I would not call them as metastasis arising from the dominant mass. Therefore, I would not give this as would not make it stage 4 M1A disease, but I would keep it as make the classification based on the dominant tumor itself. These tumors also tend to have different rates of growth. If it is possible, if you have prior imaging to understand what is the rate of growth. These tumors tend not to have nodal or systemic metastasis. Whereas if it is a metastasis arising from a dominant cancer in the lung itself, then they tend to have a similar imaging appearance. They all tend to have the same type of density, and they tend to have similar growth patterns. All the nodules we see along with the dominant nodule tend to grow at the same rate, and more importantly, they tend to also have a nodal metastasis and other evidence of systemic metastasis. So once you have decided the T, N, and M, then you have to fit this into the table to figure out what is their lung cancer stage. So the lung cancer stage also has evolved so much now. It is now divided into stage 1A, and then again A is divided into 1, 2, 3. Then stage 2 has got A and B. Then stage 4 again has got A and B, and stage 3 has got A, B, and C. So based on these things, treatment options are offered. But in general, when surgery is possible, surgery should always be performed. For stages 1 and 2, surgery should always be offered unless there is a strong reason not to perform surgery. In select cases, definitive radiation therapy can be offered as an alternate to surgery. For stage 4, it's always non-surgical treatment in the combination of just chemotherapy alone, or it could be chemotherapy with radiation. For stage 3, I would say most centers do not choose surgery except in some special circumstances where neoadjuvant therapy can be offered to downstage the tumor then perform surgery. So we talked so much about T&M staging. The question is, do we report the T&M staging when you're looking at patients with lung cancer on their imaging studies? So actually, we do not. We describe the tumor size, extent. We talk about the distal effects such as atelectasis or pneumonia. We mention all the lymph nodes which we think are suspicious. Then if we think something is metastasis, we describe the locations, the number. The reason is our accuracy is not very high. And if you're working in a hospital like MGH where we are highly subspecialized, I only look at the chest CTs. I do not look at the brain. I do not look at the abdomen or pelvis. So I do not really know the full extent of the tumor. But I also attend the thoracic multidisciplinary conference. When I look at all the imaging studies at the time, I have a better sense of the extent of tumor. But even then, the lymph nodes is something which causes a lot of problems for me, because when I think lymph nodes are large, I think they are metastatic lymph nodes. In some instances, they are just reactive lymph nodes. So in many situations, again, we have to rely on biopsy for the lymph nodes. But if it's a clear-cut metastasis outside the lymph nodes, it's much easier to determine the stage of the cancer. So we did not assign the TNM staging in the reporting on the imaging studies. But when we sit in the multidisciplinary tumor conference, tumor board, we go into these details. And almost all the patients who are treated in our oncology clinic I offer my input regarding the TNM staging. So thank you very much. I'm happy to take any questions.